Hello, everyone, and welcome to today's webinar on COVID-19 and the shift to telemedicine. My name is Jonathan Sullivan, and I'm the Vice President of Product and Membership Design at the National Quality Forum. Welcome to this special program on how NQF members are responding to the challenges around COVID-19. We started this series a few weeks ago, and we're continuing today. We appreciate everyone taking the time amidst this crisis to participate, and we hope that it'll be informative for you as you face the many challenges that are present right now and are going to continue to be with us for a while, it looks like. We're especially grateful to today's speaker, Dr. Judd Hollander, for taking a break from the COVID-19 response to share with us what Jefferson Health has been doing so that we can benefit from their experience. Dr. Hollander is Associate Dean for Strategic Health Initiatives at Sidney Kimmel Medical College at Thomas Jefferson University and Professor and Vice Chair of Finance and Healthcare Enterprises in the Department of Emergency Medicine. He's responsible for identifying, developing, implementing, and measuring the success of innovative healthcare delivery opportunities across the enterprise. These initiatives have included JeffConnect, the National Academic Center for Telehealth, and Jefferson Urgent Care. Dr. Hollander also has a well-funded emergency medicine clinical research program focused on risk stratification and treatment of patients with potential acute coronary syndromes and congestive heart failure. Some quick logistics as we get started. We hope that you'll take an active role in the program, speaking up during the question and answer portion. However, please help us stay on topic and refrain from questions or comments that aren't related to the information being shared today. We have 118 folks on the call as of this moment, so we've muted all phone lines to ensure that unexpected noise doesn't interfere with the program. When you're ready to speak, hover your there's two ways that you can participate. I'm going to put them up on the slides right now for people who are on the web version, and I'll explain to everyone how it works. If you're on the web version and you're ready to speak, you can select the option to raise your hand. You can hover your cursor over the screen and select the option to raise your hand. When it's your turn, I'll ask you to hit *7 on your phone to unmute your line. And when you've asked your question, please mute your line again by hitting *6. You can also feel free at any time to post questions in the chat box, and I can either call on you when it's your turn to have you ask the question, or I'll ask it on your behalf. If you are not on the web, if you're on the web, we have these instructions up on the screen for you to see. If you're not on the web, when it comes time for phone callers to ask questions, I'll repeat the instructions for you about what you need to do. So with that, I would like to turn it over to National Quality Forum CEO, Dr. Shantanu Agrawal, to kick off the program. Shantanu, you can hit *7 on your phone to unmute your line.
Thank you, Jonathan. Can you hear me?
Yes.
Excellent. Well, I just want to welcome you all again to this webinar series. I think it's been very meaningful to have these speakers on and to hear from them what it feels like on the front lines, especially in areas that I think are extremely germane, like telehealth, as we're discussing today. I really want to thank Judd Hollander for doing this. Again, he's an emergency medicine physician, which I think we've all seen on the news what that means, and the great amount of effort and self-sacrifice that ER docs are putting into responding to this pandemic. Judd and I actually go back. He was one of my attendings when I was in residency at UPenn in Philadelphia. So Judd, thank you so much for doing this. Judd has also served, in addition to his many other achievements, more notable achievements, he's also served as co-chair of our telehealth committee some 18 months or 24 months ago. And that report is available on our website for anyone who wants to read it. Again, Judd, thank you for doing this. Thank you for taking time out of your day and for not only telling us about how telemedicine is involved in responding to the pandemic, the incredible rise in telemedicine, frankly, in the last few weeks, but also what the future might look like now that we've all gotten this experience. So with that, I'll turn it back to Jonathan and Judd.
Thanks, Shantanu. I'm going to turn it over to Judd now to give a couple opening remarks, and then I have some questions to get us kicked off today. Judd, you can hit start. I think you're already unmuted, so you can go ahead and start speaking.
Yeah, so I think I'm just going to summarize what's happened at Jefferson over the last couple of weeks. We have had a program that started in 2014, 2015. We did about 300 calls a day on our peak days through a variety of different use cases. We were fortunate in that we had a program across many, many different use cases, all of which were scalable when COVID hit. We were not smart enough to know there was going to be a pandemic, but from the top down, we believed that care was going to move to a more virtual model over the next decade or so. And my charge from my CEO, Dr. Steve Klasko, who is very visionary, was to build a program, prove it could work, and make it so we could scale it up when the time was right. Again, not visionary enough to know that this was going to be the time, but briefly, we have an on-demand program that Dr. Aditi Joshi runs. We have a scheduled visit program. We have an ED teletriage program. We have a transitions to home program. And to give you an idea, we celebrated in September of 2019 our 100,000th audio-video synchronous visit with our own providers. We don't kick out to any of the provider networks. And we thought that was certainly among the tops in the country for pure audio-video synchronous telemedicine. And when I talk about telemedicine, mostly that's what I'm referring to. That was 100,000 visits over 4 years. We will do 100,000 visits this quarter since COVID hit. We have a 20-fold increase in the on-demand program that Dr. Joshi runs. We have a 50-fold increase in our scheduled visit program. We are rolling out an inpatient program based on a small but successful virtual round program that we have. And we believe that it is just as important to take care of all the patients who don't have COVID as the patients who do have COVID. And so as one metric, our Department of Medicine used to do a single-digit percentage of their calls via telemedicine. Right now, 90% of their visits are being done by telemedicine. So we've been fortunate. We had a baseline program. Our challenge has been to scale it across the enterprise and take care of our patients. And I will walk you through many of the things we've done, many of the bumps we've hit, and the way we're thinking about going forward, not just for the rest of this COVID pandemic, but in the post-COVID era. Jonathan, I will turn it back to you.
Great. That's a great introduction. You guys have so much experience doing this, and you quoted your statistics about the rate of adoption that you've had, rate of utilization, I should say, of this going up so dramatically in the past few weeks. What would you say to other health systems that maybe are not as far down the path with using telehealth technologies? What would you say some of the things that they should be keeping in mind are as they shift more of their patient visits to this channel?
So I think there's two broad categories the way I think about it. There are programs that have some telehealth and have figured out the logistics of telehealth and how to run a scalable, durable program. And there are programs that have heard the word telehealth but have no idea what it is. And those two programs need to approach the rollout differently. So to get not too in the weeds, if you have a program, you don't want to give up all the regulatory requirements you've worked through. We know that the federal government has relaxed short-term requirements. They've relaxed the use of secure networks. They've relaxed HIPAA. They've relaxed the type of platforms that you can use, allowing people to potentially use things like FaceTime and Skype. Those things are not at all good long-term solutions because all those temporarily relaxed rules are going to come back in. So our program made a decision that since we can take care of patients with the platforms that meet the requirements before the relaxation, we should continue on our path and scale those. If you don't have a program at all and you're trying to figure out how can your provider on Tuesday figure out how to see a patient on Wednesday, well, then those solutions are going to be much better for you in the short term. But as much as we're all in crisis mode, we have to think about post-crisis mode too. So as you roll out the program and you're deciding what to do if you're new, start thinking about what you're going to do in 3, 4, or 5 months from now when those relaxed requirements no longer exist.
Yeah, because this isn't just, we're looking at a situation where there's going to be a certain amount of capacity that's going to stay on the telehealth channel going forward. I think once people get used to it, don't you believe that this channel will tend to be more widely adopted going forward, but you want to do it in the right way?
That's exactly the big issue, and that's one of the things that we struggle with and everybody on this call probably struggles with. We have in Pennsylvania, we are one of the 8 or so states that have no telehealth laws. No parity, no coverage parity, no payment parity. We're out there where each payer can do whatever they want. Of course, payers being not payers as their priority are often not paying for the visit and returning money to the shareholders, as they're actually supposed to do. Most of the payers, in fact, almost all of the payers across the country, are now actually paying for telehealth, but they're making it difficult for people like me who run programs to know how to go forward. So an example might be that you have a telehealth platform that doesn't take insurance verification, real-time insurance eligibility checks, because nobody was paying for it. So now I want to know, do I need to build that into my platform or not? But my local payers come most commonly in one of 2 breeds. One is, we're going to pay for everything, but only till some date in June or until the crisis goes away. Okay, that's a problem because I don't want to spend tens or hundreds of thousands of dollars redesigning my platform so that I can not be able to use it come June, and all the things I build into it I won't have. And the other form is, we'll pay for everything that's COVID related. Well, what happens if you have a 3-year-old that has a fever and it turns out they have otitis media? Mom called with the fever, but they turned out to have otitis media. Now that's not covered. So I don't know how to go forward and how to build these short-term relaxed guidelines into my long-term plan. And those are the issues that keep, circulating for me. And we see all this adoption now. I think patients are going to push it forward, so we can't go all the way back to where we were, but where we settle out is still unclear.
All right, well, we've got our first question from the audience, and that's going to be from Joseph Stillo. Joseph, do you want to hit *7 to unmute your phone and ask your question?
Thank you. Can you hear me all right?
Yes.
Yes. Dr. Hollander, thank you for the information. Not being that in tune with telemedicine in general, I know that my organization is considering and obviously expanding our ability to do it. But the question that keeps coming up, and probably I bring it up more than others, is what is the human interface on the patient side of the visit? How do you examine the patient? Do you have trained personnel to actually give the physician who is performing the encounter the information that the physician needs?
Yeah, so it depends on, so the one thing I want to say up front, and that's a great question, Joe, is telemedicine is not for everybody all of the time. But telemedicine, when used well, can help take care of a large majority of the patients. And before I directly answer your question, let me say that when a patient comes to see me in the emergency department, right, which is the place where we assume we have the most resources ever available, when I initially evaluate the patient, with or without a physical exam, I come to a working differential diagnosis. But then what I do is I might order lab tests, or I might order an x-ray, or I might require somebody with more intellectual horsepower in an area, and I get a consultant. I'm not providing emergency room care. I'm providing emergency care. And the same is true with telemedicine. If I'm a pulmonologist or I'm a pediatrician, I'm providing pediatric care. Telemedicine is just the lens through which I view the patient, just like it's my eyeglasses or my contact lenses. And so I'm still practicing the same form of medicine. And I like to say, and this is in the National Quality Forum report that Shantanu referenced, that what we need to do every time we see a patient is get to the right actionable information. And sometimes I can't do that without help in the emergency department, and sometimes I can't do that without help on telemedicine or in an office visit. So I have to know when I've hit my limitations as the first point. Now I'll directly answer your question. You are examining the patient, and you can examine the patient. So no one would argue that I'm clearly looking at the patient. I'm seeing if they're breathing easily. For those of you that have a medical background, I'm seeing if they have intercostal retractions. I could do almost a full HEENT exam for the head and neck, with the exception of looking at in the ears without external devices. I can walk the patient to the window to get a better look in their throat. And I can see the cardiorespiratory exam to see the breathing. I can't listen to heart sounds, but I can make them take a pulse, count it out loud, time the pulse, and know whether it's regular or irregular. I do that well. I see if they're short of breath. I employ family members to help with the abdominal exam. If they have a tablet or computer, it could be put at the foot of the bed or couch. The patient could lie down, and I could teach somebody really quickly how to touch that patient's belly, ask them the same questions as when I'm palpating their abdomen, and look at their facial response the same way I would if I was standing in the room. It's just somebody else's hand. I can do a near complete neurologic exam, or at least a good enough neurologic exam, to address most but not all neuro things. So it is an exam. The only parts of the exam, the only three things I can't do generally are look in the ears, listen to the lungs, and listen to the heart. And for many, many patients, that's not really that important. We know for years pulmonologists and internists have dealt with asthma patients on the phone, right? Now I'm seeing them. I have more information on the phone, and I get something that's not considered part of the physical exam. And I could argue with no data it's more important than the physical exam. I get a look into their home. So when I see post-op patients that I worry maybe they're not able to take care of themselves and their house is immaculate, I know somebody's taking good care of them at home. When I see them in the office and they're all dressed in the same blue gown with the back open, put on backwards, everybody looks the same, and I have no idea what's happening in their home. So I am trading a lung exam or listening to the lungs and listening to the heart for a view into the home. And we don't know the answer to this yet, but I might argue that that is a very valuable trade-off. It gives me more information than I get in an office visit.
Well, thank you for that. I really appreciate that. That's insights I have never had, honestly. And I know that from the aspect of an emergency visit, I can see that. I'm a physiatrist, and most of my patients are in inpatient rehabilitation setting. And, you know, we are expected by CMS to do ongoing neuromusculoskeletal examinations. And, you know, I can understand, for example, with a manual muscle test that, you know, asking somebody to lift a leg off the bed would be okay. They've got full anti-gravity, at least a 3 out of 5. But, you know, we're looking for really more subtle, important changes in musculoskeletal strength, range of motion, those kinds of things. I can understand where wound checks, as long as you have somebody on the other side who can get the camera to where you need it, would be valuable. Because I think that, you know, with a lot of the hands-on stuff that we need to do, there's certainly potential, and we always say we're moving toward having a trained person on the other side of that visit, especially for in-hospital telemetry care, telemedicine, not telemetry, telemedicine. But thank you for your insights. It's very interesting to hear your question, your answer, Dr. Hollander. Thank you very much.
Yeah, and I'll follow up with that again, it's not perfect for everything, but we have found it's better than you might expect for many things that you think there's no way it can do, and it has different advantages. So I will take a laceration. Clearly, I cannot sew a laceration on telemedicine, and we're not yet at the point where I'm going to teach most family members to do that, right? But a laceration that happens at 9 at night when you're the sole parent of 3 young children, I can teach you how to wash out and bandage and do enough of an exam to see that you don't have a neurovascular injury and say, you know what, you can clean that out and go see somebody in urgent care tomorrow rather than take your 3 kids to sit in the ER for 6 hours tonight. So it might not be applicable exactly to the setting you described, but if you play the game through simulation and say, you don't have an option for inpatient care now, how would you manage it? It's amazing what you can figure out.
Thank you so much. I really appreciate it.
So, Dr. Hollander, this brings up a good challenge, I think, that probably a lot of organizations that are newer to telemedicine are facing, and that's physician training. I mean, even at your organization, you probably have more than the average number of trained physicians, but I'm sure even in your case, you're having to train additional people to meet this need. What are some good resources out there that can help clinicians get more comfortable with doing the kinds of remote exams you just described? I mean, even just what you described in the past few minutes, I'm sure would be really illuminating for a lot of people.
Well, now you're going to force me to disclose a conflict of interest. So we at Jefferson, under the guidance of Dr. Joshi, who I mentioned before, have put together, it's basically 6 10-minute CME modules on how to do a physical exam, which is open to the public, that you could go on, register. There's a cost associated with the CME that comes with it, but you can go see, and that's a really good first stop. I don't know whether the other telehealth resource centers have something similar, to be honest, but it's a nice way to, in an hour, go through 6 of the modules and see what it is. We had, when we rolled out, we used to have a weekly meeting of all the people that were doing telemedicine when it was a first group of only 20 of us rather than 1,000 plus now, and say, what did you learn? What did you figure out? And sometimes they were technical tricks, like what if this browser doesn't work? And sometimes they were, I need to splint a wrist. What do people have around the house? And we learned how to do it with shoe boxes and cutting things out. So it really is a matter of when you're out there on your own, it's really hard to be more creative than you naturally are, and people stay in the care delivery mechanism they've been using forever. But talking to other people, and unfortunately we don't really have conferences anymore, but webinars like this where people can share ideas are good. And then again, disclosing their self-interest in this, though I don't make money off it, Jefferson has some CME modules where you can go through and see how to do the physical exam.
Great. We'll get the link to that we can share with the audience after the webinar is over. So we've got a few questions here in the chat window. The next one is going to be from Amy Lippert. Amy, do you want to hit *7 on your phone to unmute your line and ask your question?
Hi, can everyone hear me?
Yes.
Hello. Dr. Hollander, thank you. I'm an associate at the National Council of State Boards of Nursing, and we've actually been actively developing some international guidelines for telehealth nursing just in development before the pandemic hit. And I was just curious on hearing your perspective about, this does not have to be COVID specific, but perhaps thinking long term for, what are the optimal or most potentially effective regulatory measures, or the opposite, regulations that have really hampered your ability to deliver quality care. Obviously, we're approaching this from a nursing standpoint, but I think this applies across telemedicine as we think long range and increasingly globally. We're just trying to, approach this from a regulatory standpoint and thinking about best practices, or what some of the, the worst practices are, so to speak.
Right.
Thank you.
So I think from a regulatory standpoint, I wish I had power to solve some of these problems, but what, at least on the physician side where I'm more familiar, and I imagine the same is true on the nursing side, is I have 19 states worth of licensing. That basically is a full-time job for me to keep up and get the right specific CME and everything else. And every time I get a renewal, I ask myself the question, just because it annoys me, how often does someone who's licensed in good standing in 18 states not get the license approved from the 19th state? And why do I need to fill out pages of forms? I think I was honestly fingerprinted 11 times to get the 19 licenses, most of that in a 3-month period. I couldn't commit enough crimes to need that many fingerprints. The process is ridiculous, but it's at the state level. And so until the states decide they're going to give up the revenue and fold on the office and trust the federal process, it's not up to the federal government to federalize it. And that comes back to a point that's important in many things the administration has said in an attempt to make it easier to do telemedicine now. They can stand up and say they're relaxing state licensing requirements, but they're actually not in charge of state licensing requirements. So the fact that they say, I don't need a license to practice in Minnesota, doesn't mean I'm practicing in good standing in Minnesota if I opt to do it. I think what they really meant to say is, if you're not licensed in the state and you bill CMS for caring for somebody, we'll pay for it. But many of these things are very confusing to deal with. And so I would advocate, the thing I would like to happen is that if you're licensed in good standing in one state, or even if it's 3 states, you're licensed in good standing across the United States, and we could function as United States. I don't know a way to get there, because it requires people to give up revenue and change their medical board and change self-control. And so I will answer questions as the one you asked in a good faith effort, but I don't have a real path forward. And, you know, the amount of time it's going to take to change that just seems like I'll be retired by then.
Okay, well, hopefully that won't be the case. Our next question is going to be from John Matulis. John, do you want to hit *7 on your phone to ask your question?
Yes, great. Thank you for the time and for this very thoughtful and interesting presentation. I am a primary care internist, and I'm curious about sort of coupling telehealth with remote monitoring. And maybe that's for our diabetic patients with blood sugar data or blood pressure data. And I just was hoping you could talk a little bit about your experiences there. Thank you very much.
Yeah, absolutely. It's a totally wonderful thing to do. It doesn't make a lot of sense to me, or obviously you, to have someone just come back to the office of the lab to get their hemoglobin A1C checked. And actually, one of the people I work with, Dr. Bruce Meyer, said this best. A hemoglobin A1C is a look at history. It's not a look at where the patient is now, right? But that's what most of our pay-for-performance measures are tied to. What we really want to know is, how is your blood sugar controlled now, and how can I make it better controlled in the future? And these remote monitoring devices are the way to do that. And that ties back into big reimbursement questions, because if you could take care of your diabetic by having a telemedicine visit with them, by having their nutritionist have a telemedicine visit with them, and by you seeing their data but never even seeing the patient face-to-face, well, the goal is about quality of care. It's not about an in-person interaction. And there's no doubt some doctors and some patients need that in-person interaction, but many don't. And so I think we have to start paying for the care that's delivered rather than paying for the manner that the care is delivered through. And so from my point of view, remote monitoring of diabetics, telemedicine visits with people who otherwise cancel their appointments 30% of the time or have difficulty getting in is a much better medical model than in-person care. And I'll give a roundabout answer to that for everybody for questions that will come up. Could you imagine the day, I mean, say COVID stays or the system doesn't go back, and a large percentage of our visits are done by telemedicine and remote monitoring. And then say somebody comes up with this brilliant idea that it'd be really good for patients to have to get in the car, drive downtown, pay for parking, and go see the doctor in a bricks and mortar building. And medical centers would have to build buildings, and they'd have to house doctors, and we would do away with telemedicine and remote monitoring. Would any person in the world sign up for that care delivery system? Nobody would. But yet nobody wants to move to the one that they would never leave. So I think your question is will it work? Of course it'll work. It's a great thing to do. It's how are we going to get people to reimburse it, because it's a much more efficient system.
Okay, great. So moving on to the next question. This is from Boston Children's Hospital. I'm sorry their name didn't show up on your organization name. Hopefully you know who you are, so I'll give you a minute to hit *7 on your phone and unmute your line. Okay, I'll ask the question for them. The question is, what measures, especially outcomes, are you tracking to quantify the value of the telehealth encounters with the aim to inform sustainability of virtual care post-COVID?
So we've been tracking a lot of measures pre-COVID, and I'll say that, and this comes right out of the NQF report. So as Shantanu mentioned, I co-chaired the committee with Marsha Ward on developing a framework for telehealth measures going forward. And there were 4 things that were important. They were access, they were financial cost and cost effectiveness, they were experience, not just satisfaction, and effectiveness. And I think all of those need to be measured. And I like to speak to experience as the first thing, because the experience and all of these items were very in-depth in terms of the way they were focused on in the report. So it's not just the patient experience, it's patient, family, caregiver, and community. And although it's not important in COVID, many large health systems, Jefferson included, have a wonderful neurostroke network where we're out in 38 hospitals, and if you come to the ER with a stroke, we can have our neurovascular specialists literally see you through a robot, see your CAT scan, and make treatment decisions. And we've proven we have better 3-month outcomes, better 6-month outcomes in terms of return to function. That's great. We've proven we could leave more people in the community rather than transfer half of the patients that would be there to downtown Philadelphia. We only transfer 17% to downtown Philadelphia, leaving more people with their family. But now, what if you're a community that had one neurologist, and that neurologist made a decent amount of their income on stroke care, and now they've lost the stroke care? And now that neurologist leaves that community. We've done great things for stroke patients, but now we can't take care of multiple sclerosis, Parkinson's, and many other neurologic conditions. So looking at it from the community experience is also important to do that. So we track things across all 4 of those domains: access, cost, experience, and effectiveness. And I'll give you one pre-COVID example. We have an employee benefits plan. Jefferson has over 30,000 employees and dependents, and our telemedicine platform is called JeffConnect, and it's generally staffed by ER docs, the same people that work in our ER. So we said, if you're in our employee benefit pool and you call JeffConnect or do a video visit with JeffConnect, and the ER doc says, I can't take care of you via telemedicine, you should go to the ER, then we're going to wipe out your copay. Otherwise, you'd have a $250 copay, but we'll wipe it out to encourage you to see the ER doc remotely. Okay? If we send you to urgent care, we'll wipe out your urgent care copay. If you show up in the ER and you're admitted, we'll wipe out the admission copay for you. So our volume, as you might expect, went up reasonably dramatically overnight when we announced that program. We have improved access because we've gone up to many, many more patients who can be seen from home, and we have data on how much that access has improved. We've demonstrated cost effectiveness because we've actually cut 5% out of our healthcare budget for our healthcare insurance. And, you could make up the math, but at 30,000 plus employees, that's not a trivial amount of money. It's well into the millions. We do surveys on the experience, and our net promoter score, some months is as high as 90. In our lowest months, it's as low as 70. So it's way better than other things we do in the health system or across the board. And our effectiveness shows we've been able to drive down emergency department admissions, and a very high percentage of people we send to the emergency department actually get a procedure or an admission or a CAT scan suggesting that they needed to be in the emergency department. So across all 4 of those domains, we've demonstrated that program works nicely, and we measure other programs similarly.
So that question was from Richard Antonelli. Richard, did you want to ask a follow-up?
Is that okay? Can you hear me now?
Yes, we can hear you.
Yeah, thank you. This is so helpful. We're doing some work right now at Boston Children's where we're not trying simply to show that telehealth can take the place of face-to-face visits, but in fact, what's the value add of telehealth connection? And I think some of the work that you're describing is in that space. And we're looking at patients that have long-standing chronic, especially complex conditions that need a lot of care coordination over time, and we're finding that the development of a plan of care that then gets implemented in partnership with the patient, family, and the caregiver, that in fact the virtual visit will have a huge level of opportunity for convenience and closing the loop on some of the care coordination measures that in general we struggle with for chronic care needs. So I appreciate everything that you're doing in Philadelphia, and thanks for the presentation today.
Yeah, and thanks, Richard. I'll add to your comments because I think the way you just described it is actually brilliant, and it may have been lost on people on the phone. It's not telemedicine or in-person. It's really standard of care with and without telemedicine. So there are a few patients that we see, and we do have a couple, that are only seen via telemedicine. Telemedicine is a way to supplement the regular care they're provided and a way to sort of close gaps as well. And you said that, but I want to specifically point that out because that is a really, really critical point. It's not telemedicine or not. It's usual care, and then when and where is it best to layer on telemedicine?
Yeah. And as Shantanu knows, we're globally struggling with meaningful measures of care coordination. We actually think that virtual care that the family is relying on and that the system is able to do more effective population management in this space. So the value add of virtual health is what we're aiming for. And once again, thank you.
Okay, thank you.
Okay, our next question is going to be from Kimberly Berryalt. Kimberly, do you want to hit *7 on your phone to unmute your line and ask your question? Okay, since we're not hearing Kimberly, I'm going to read her question. What do you recommend for ensuring a caring patient experience?
So I don't know that I fully understand the question, but I will give a couple examples. And again, I said at the beginning, and I want to re-stress this, telemedicine isn't for every patient, for every situation, for every time. But we as physicians tend to overvalue relative to patients the physician-patient interaction. And so I'll give you one example, which is the getting on giving bad news. So we as physicians, and I used to as well, think that it's really important to sit, and hold the patient's hands and look them in the eye and give them bad news. And then we had a couple patients that actually asked to get biopsy results and stuff by telemedicine. And I started thinking about it, and I started talking to people. And what I learned, and this may not be the best analogy, but it's the one I use. You know how shaken up you are after you've been in a minor car accident? Because I imagine most of the 125 people on the call have had that happen to them. You're shaken up for hours, totally disproportionately over the amount of impact you got in the event. Well, for those of you that don't have healthcare problems or don't tell people about healthcare problems, now imagine you just drove 75 miles and your doctor told you have cancer and you need to drive home. And you, of course, can't think of the questions that you have when you're in the doctor's office, but the whole way home, you're imagining everything being horrible. Turns out that if you ask patients, many of them, not all of them, but certainly a sizable group of them, would you rather be sitting in your living room with all your family around when we discuss the biopsy results and next steps? Many say yes. They find that a more caring, compassionate environment because it's not the physician they want around, it's everybody else they want around. And they can't have everybody else around on a Tuesday at 3 o'clock when the physicians are in the office. But they can have everybody around if they don't have to travel and they don't have to come a distance, and the call can be taken early evening before the physician goes home. So again, we have found the best thing to do is ask the patient and deliver patient-centered care with this novel thing. It's the way the patient wants the care to be delivered, not the way the health system wants to deliver it. So hopefully that answers that question.
Yeah, I don't want to speak for Kimberly, but I think that gets to the part of this concern that somehow a telehealth visit with your doctor might be less caring or have some of the human elements that you would get from an in-person visit. But I think you bring up a really interesting example, and if we really try to think about this in a whole new way, like maybe it actually can provide for a more humane experience under some circumstances. So I think it just goes to show that there's a lot more to this than perhaps meets the eye, and that's why it's good for us all to be asking these questions and talking about it. So we're going to go to Rajiv Pramanik next. Rajiv has a question. If you want to hit *7 on your phone, Rajiv, you can go ahead and ask your question.
Good morning, thank you, or good afternoon over there. We're on the West Coast. So I was asking about more the care coordination, and I know you're working in the emergency department type processes, but I'd like to hear more on the virtual process. We've done a lot of ambulatory work and now we're trying to develop more virtual medical assistants to pre-call, post-call, and share the burden, because initially when we implemented it was docs or other providers on their own doing all of it, and just want to understand or things we can learn from based on your experiences.
Yeah, so I think actually that's a great question, and is, I don't want to say a problem, but is an area that needs to be further developed by many of the technology partners that we and probably obviously you work with. We would love to be able to have, when we do our on-demand call, if I'm the doctor on call, I need to take the patient information, I need to register them, I need to send them their discharge instructions. I do everything. We've streamlined processes to make that work, but much more ideal would be you came on and an MA took your information, because it would open up the world for me to be able to take down insurance information and not be a cash-only business or a credit card-only business. And I would now be able to take care of Medicare and Medicaid patients, and process the insurance appropriately. Right now, most of the platforms don't do that. So it would be really helpful to be able to have somebody who comes into a waiting room, gets information that mirrors office flow or completes it on the chatbot, and then gets passed off to the physician, and could even potentially get circled back to the post-discharge care to have the next appointment made. So I think right now we haven't had that or fully lined up in most of the platforms, and we are actually very dependent on physicians doing everything, which isn't the most cost-effective way, but is the way we're working right now. So I share your wish for that to improve.
Thank you.
So our next question is going to be from Susan Gerard. Susan, do you want to hit *7 on your phone to ask your question? Okay, I'm not hearing Susan, so I'm going to go ahead and read her question. Do you think CMS should or will expand the services they currently cover for telemedicine and also relax the patient location stipulations for covered telemedicine services prior to COVID?
I like to say the only thing I know for certain is that the world will remain uncertain during this time. But I have to hazard a guess, yes, because my understanding, and as much as I didn't want to get involved in the politics of this, I've been down to D.C. to lobby, and I've met with people, in there. And my understanding, and I can't swear this is the major impediment, but it's at least the impediment I hear, is that we've not been able to really price out. The CBO has not been able to really price out what would be the cost to CMS if they embrace telemedicine more. But there's no human being apparently, or I shouldn't say no, it sounds too definitive. There is bipartisan support across both the House and Senate for enhancing telemedicine, but there is fear that the finances will break the bank. I think seeing what happens during COVID might actually finally provide the amount of data within CMS's claims management system that they will be able to model and see that it's not going to break the bank. So I am hopeful that the rules that they have relaxed and the reimbursement policies that now exist during COVID will, even if they go away temporarily whenever a disaster is lifted, be able to come back permanently down the road.
Okay, we're ready to go to the phones to see if anybody who is on the phone and not on the web has a question. If anyone has a question at this time, we'll pause and you can hit *7 on your phone to unmute your line and ask your question.
Hi, this is Rajiv again. I had a question around in your telehealth and also maybe future thinking. Are you doing mostly audio only? Have you been incorporating video in certain parts? Because that adds a layer of complexity with the patient. And where do you see payment differentiation based on that type of service?
I think that there will absolutely, post-COVID, be payment differentiation based on that type of service. My answer to the gentleman who asked about the physical exam earlier, I think I can do a physical exam on video. I don't believe I can do much of a physical exam on telephone. Video is new. Telephone is old. It's really going to be a hard push to get people to pay for something that's been free and is entirely abundant in the payment models. So I would not be optimistic that either email or unstructured email or telephone are going to be payment models that survive. I'm optimistic that synchronous audio video will be a payment model that will survive. In our program, in all those use cases, in the hundreds of thousands of calls that we've done, they all have a video component. We actually do not count, we do telephone calls and we do email. We don't count that in our telehealth numbers. I know there are health systems in the country that proudly boast that more than 50% of their visits are done via telehealth. But I actually know from most of the health systems that say that audio video synchronous telehealth is a teeny fraction of that number. So I think that's something different. It's really hard to get people to pay for things they've never paid for before. So I think we'll see the payment models change for video and not for things that don't include video.
So our next question is going to be from Donald Goldberg. Donald, do you want to hit *7 on your phone to unmute your line?
Dr. Hollander, again, a great presentation that will echo what everyone else has been saying. Question for you is, given that most practices today now have been using virtual care as they've shut their practice for the last several weeks, assuming that there are regulatory changes, reimbursement changes to reflect the new world, do you see more physicians adopting virtual care as part of their eco model going forward within their private practices?
So, that's a fascinating question. The answer will clearly be yes. What I don't know is how much more. I used to fully believe that virtual care adoption was going to be entirely driven by the patients, but our own surveys of our scheduled visit shows that about 3/4 of the time the patient does their first visit, it's because the provider suggested it. And my clinical experience is that when you say to a patient, would you rather do this by telemedicine or in person? They all say in person, but when you say, hey, we're going to do your next visit via telemedicine, they all say great. So I think the providers drive a lot of the adoption before COVID. Now that patients are going to get an experience of it on their own and know better what it is, I don't know if that will flip on its head and patients will drive increased adoption, and those providers that don't want to do telemedicine may be left in the dust. But one way or the other, we'll see telemedicine be much more commonly used. We're trying to get a handle on that at Jefferson and say, what happens to all of our healthcare models if 10% becomes telemedicine, 20% becomes telemedicine, or 70% becomes telemedicine? How do we prepare for a day where we know there will be more telemedicine, but we don't know how much? And how do we stay financially afloat in that day.
Thank you.
Our next question is going to be from Mike Curie. Mike, do you want to ask your question now? Remember, hit *7 on your phone to unmute.
Hi, can you hear me?
Yes.
Yep.
Great. I'm just curious. Have you observed any difference in telemedicine use between genders, males and females, or across age groups, and definitely across different races and ethnicities?
So that is a wonderful, great question. My answer will reflect both what we've observed and the area we are in. So I can't comment on racial differences, especially if I were to control for income and smartphone use. That I can't answer that part of the question. I can tell you that about 60 to 65% of the people who call in are female, and the remainders are male. So it's more female than male. I can tell you the most common age group is sort of the 30 to 60-year-old range. The men that use it tend to be an average age about 10 years older than the women that use it. But I will tell you that we have 90-year-olds use it, and we have parents using it on 2-day-olds. I'm not sure we've seen a 1-day-old. I know we've seen 2-day-olds. And I know we've been well into the 90s. I don't know that we've ever seen anybody over 100. So, that's another thing. And so I haven't said this yet. So that leads to a good point. The thing I've learned most about telemedicine is if I think too hard about it, I'm going to get it wrong. So I, again, should leave it in the patient and the doctor's hands as to when it's useful. And much like the bad news scenario I gave before, in our urology practice, and the urologist published this, the third most common use for telemedicine was post-vasectomy care. If you were to come to me and say, hey, Dr. Hollander, let's build a program around people that had vasectomies and let them show this on telemedicine, I would tell you you're crazy. But yet, I guess it hurts and people don't want to get in the car and come back. And it turns out that that's a perfectly good use case that our urologists are using it a lot for. We wouldn't have guessed. Post-mastectomy care, very similar thing. Every doc's like, no, I don't think they're going to want to do that. Well, it turns out sitting alone in a paper gown in an exam room with people coming in and out looking for rulers isn't the best experience for women that have had a mastectomy either. And only seeing the physician on video is more comforting for some, but not all women, and is an option for what they're doing. So same thing in the age group. You will naturally think, and probably be right, that 90-year-olds are less likely to do telemedicine. However, 90-year-olds are also less likely to drive to the doctor or take the bus to the doctor. And what happens is a 60-year-old family member comes to take them. That 60-year-old family member can do telemedicine with that 90-year-old family member, and it's a lot more convenient for both of them. So when we start saying, okay, how can we make this happen for you? It turns out, and we leave our preconceived biases aside, we can deliver care to many, many more people.
So we have time for only a couple more questions. I want to make sure that that we've gotten all the questions from folks who are not on the web and only on the phone. Is there anybody else who's only on the phone who has a question?
Again, it's Mike Curry. Thank you very much for the answer across genders and age groups. Anything that you've observed across race and ethnicity?
I can't really comment on race and ethnicity because I just don't know. I mean, we're in an area that, most of our callers are white, but most of our patient population is white. We have a decent amount of African-American population. They as well are using it. We don't have a widely robust translator service, so we also have a large Asian population, but they're less likely to use telemedicine because we're less well equipped at this point to handle that. So I can't say that I see a clear pattern one way or the other, particularly after I might adjust for what kind of insurances they have and whether or not they can pay cash for the business.
Great. Thanks.
Any other questions from the phone? Okay, we've got a couple more in the chat.
Oh.
Sorry, go ahead.
Oh, hi. Hi, can you hear me? This is my name's Casey Fee. I work at Boston Children's Hospital as well. I wanted to ask, given the numbers that you gave, that you're going to do as many telemedicine visits in a quarter that you did over 4 years, and that you were a front runner in this area, it certainly isn't hyperbole to say that this is the largest operational shift in the healthcare industry, I think, in recent times. I was wondering, noting that there are other technological shifts that are awaiting, thinking of health information exchange, care planning, better integration across care teams. Do you think, are any predictions about what this change in telemedicine, if it might kick off something new in the healthcare industry in terms of acceptance and speed at which change can be adopted?
Yeah, so I think you used the word change a couple times, and that's the key word. And I've been saying for years that telemedicine is nothing but a healthcare delivery mechanism. And like I said before, nobody asks if the doctor's wearing glasses, if they're wearing contact lenses. You don't go to see your third floor doctor or your fifth floor doctor. You go to see your doctor who's a primary care doctor or a cardiologist or a pulmonologist. And telemedicine is just another floor in the hospital, except it's not a floor or in the hospital. But you're still delivering the same care. So to me, the success of telemedicine or virtual care overall is going to be heavily dependent on how much we integrate it into the care processes that currently exist. Because people don't like change. So if I had taken a doctor and said, you go home and do telemedicine on Wednesday and don't come in pre-COVID, they never would have done it. But you put a life-threatening pandemic online, and boy, they're happy to stay home and not come in on Wednesday. So that changed it a lot. But we're going to need to say, how does a normal person access care? They call the office or they go online to schedule an appointment. So we have to make it. If you call the office, you could schedule a telemedicine appointment, or you could do a chat bot. We have to make it if you go online, you could use a chat bot or schedule a telemedicine visit. We have to mirror the processes that people are familiar with and allow them to do telemedicine or do asynchronous care through those mechanisms. And the smarter we are about figuring out how that works at the individual practice level, the better it is. So I'll give you a very concrete example. When we rolled this out, pre-COVID, we trained over 1,000 people in the enterprise to do this. We had 400 or 500 regularly doing audio-video visits. But some want to do it at the end of the day. Some said, we have a pulmonologist who at the end of the day said, all my people who call me that day, I'll have my admin schedule for me to do telemedicine with at 5, 5:15, 5:30, rather than me just call them back. And that way I could see them and deliver care. Another one said, I'll take Monday morning and I'll only do telemedicine. And another one said, I'll see an in-person visit at 8:15 and I'll carry my tablet, and at 8:30 I'll see a telemedicine visit. And we made the decision to let each doctor and each practice do it however they wanted to do it. Because if I tried to force them into something they didn't want to do, adoption would have been even slower. And so I think as I look forward, it's a little more complex because the world's now spun on a dime. But what we have done is we used to, for example, in our scheduled visit program, we'd have maybe 50 or 60 of them a day. I had a team of 5 telehealth coordinators who would reach out the day before to those 50 patients or whatever number we're doing it for the first time and walk them through a practice visit, what we call the simulated visit. So when the doctor was there, we would know they'd be able to get into the doctor. Well, that's really resource intensive, but that was 50 visits. At 2,500 visits, those 5 people can't do it. But yet we still found a higher call failure rate as we scaled up. So we said, okay, that was a great best practices. How are we going to replicate that now? Well, now the center desk isn't at a desk, right? This is somebody that's laid off or furloughed who's not coming to the office because there's no patients in some of these practices. So let's train them to do that component of the work from each practice. So I think the answer is get inside of the heads of each practice, see how they work, and layer it on top.
Thank you.
All right, with that, we're at the top of the hour, so we're going to have to wrap it up. I think this has been really informative. I hope you feel the same way. Thank you, Dr. Hollander, for making the time to share with us your experiences around telemedicine. I think I certainly learned a lot, and I'm not even a clinician, so I'm sure our clinicians learned a lot as well. So please be on the lookout for a brief survey about today's program. If you could just take 60 seconds to give us your feedback, we would appreciate it. And I encourage everyone to tap into our amazing community of healthcare quality leaders as we navigate these challenges together. We have an active conversation underway on our online community, MemberConnect, and the recording of this program will be posted there probably by tomorrow. So be on the lookout for that as well. So once again, thank you, Dr. Hollander, for spending this time with us today and sharing your knowledge with us. This concludes our program, and on behalf of everyone at NQF, we wish you continued good health.
All right. Thank you all for participating. Have a good day.
Thank you.